Beyond the Basics of IPR. In this module, we will discuss the details of interproximal reduction. We'll be talking about what's IPR, the safety of the procedure, when is it performed, different dental shapes and IPR, most common reason to perform IPR, the 4 principles of IPR, armamentarium and how IPR is done. What is IPR? It is the removal of part of the enamel from the proximal surfaces of teeth to create spaces in order to be able to align them. It's pre-planned in a virtual software-based treatment setup. Is it safe? It doesn't increase the risk of developing carious lesions or periodontal issues. Literature has reported that it is safe to remove half of the thickness of proximal enamel per tooth. That is around 0.67 between mandibular centrals and 0.85 between upper centrals, for example. It's not preferable to do the maximum amount of IPR from the beginning of the treatment to avoid sensitivity, overstripping, and leaving room for more IPR in the refinement stage. IPR is performed in the following cases: when you have Bolton's discrepancy, to relieve mild to moderate crowding, close black triangles, cosmetic recontouring, and correction of an exaggerated curve of SPIE. Now, about its contraindications. It's better avoided in patients with poor oral hygiene. Although IPR doesn't increase the risk of caries, however, performing it in poor oral hygiene conditions could potentially increase the risk of developing new lesions. Small teeth, square-shaped teeth, and severely rotated teeth. For these teeth, you need to wait until you have a proper contact point to perform IPR. Some of IPR's risks are pulp exposure in young adults due to their large pulp chambers, sensitivity that can be avoided by applying fluoride after the procedure, excessive space caused by overstripping, different dental shapes and IPR. We have 3 main dental shapes: rectangular, triangular, and barrel. The rectangular-shaped teeth don't show any black triangles. IPR is not favorable due to the wide and flat contact areas that need excessive amounts of reduction to gain the desired space. Tipped teeth take up more space than when positioned vertically. This fact is true for this shape more than the other shapes. Uprighting these teeth before IPR may decrease the amount of reduction required. Moving on, IPR is not barrel-shaped teeth. Doing IPR in triangular and barrel-shaped teeth, as shown in the figures, will eliminate the black triangles and incisal embrasures respectively, which gives a better aesthetic appearance. Now we'll focus on the most common reason for performing IPR, which is resolving crowding. There are 5 ways to resolve crowding. The first one is the simplest and is used frequently in aligner treatment cases, which is expansion. The second option is proclination, which also increases the arch size and has specific indications. The third option is distalization. As we know, distalization changes the anterior-posterior relationship and the molar and canine relationship. Another way to create space is by changing the size of the teeth. In other words, stripping. The idea behind these options is to provide the dentist with multiple treatment options to resolve the apparent crowding, not through one option only, but preferably by a mix of options. A certain case might only require IPR and alignment. Another case might require IPR and expansion. It really depends on the case and the variety of factors that play a role in the treatment. The final option would be extraction and is done in severe cases. Here is an example where a mix of IPR and expansion was indicated to align teeth while preserving the general shape of the arch. We couldn't do IPR alone, compromising the arch shape, making it smaller than needed, or expand alone, making the arch shape larger than needed. Expanding the arch will lessen the amount of IPR needed, of course. Normally, we are able to gain around 5 millimeters of space when expanding, but if more space is needed, it can be gained through IPR. Hypothetically speaking, let's see this case here. We need around 8 millimeters to align the teeth, so expansion will give us up to 5 millimeters, and we'll do IPR for the remaining 3 millimeters. We have 4 principles for IPR: accuracy, timing, measurement and tracking, and patient safety. Accuracy. Remove the exact amount of tooth enamel approved in the treatment setup. Second, timing. It should be performed where the contact point is properly accessible. As you can see in the first figure, the upper right one is rotated and the contact points are not accessible. At stage 14, as it's seen in the second figure, there's a proper contact point to perform IPR. Third, measurement and tracking. Measure and keep track of the amount of IPR done. Lastly, we have patient safety. Proper cheek and tongue retraction and well-supported hands to avoid the risk of injuring the patient. Always perform IPR when the IPR sheet tells you to. But what if IPR is indicated, and when you go in to do IPR, you find the contact already open? If so, it is better to avoid IPR and keep a close watch on that contact specifically. Armamentarium. Manual diamond strips. They are for minor reductions, anterior teeth, and breaking contact points. Low-speed diamond disc. You have single-sided and double-sided discs. Also, be careful of injuring the tissues. High-speed burrs. Smallest reduction done is 0.3 to 0.4 millimeters. Be cautious when using them to avoid forming ledges, and also not to injure the soft tissues. Interproximal strips mounted on contra-angle handpiece. IPR gauge. For accurate measurement of interproximal space. Guard applied on the discs to protect the soft tissues. In this video, we'll be seeing how IPR is performed. Take a diamond strip, hold it properly with your fingers, and start sawing between the teeth from the incisal edge towards the gingiva to break the contact. Once the contact is open, you can use a low-speed diamond disc to do the proper reduction needed. Take the right-sized gauge and slide it where IPR has been performed to ensure the correct amount has been removed. Don't force it in. If it's tight, do more reduction. Lastly, apply fluoride varnish to avoid post-operative sensitivity. Beyond the basics of attachments. In this module, we will be talking about attachments with clear aligners. Course outline will include: what are attachments and why do we need them? Attachments' functions, shapes, and uses. Patient's acceptance of attachments. And then we'll run through how to place attachments. And lastly, we'll talk about some other features with clear aligners, such as bite ramps. Attachments are an important part of Aeon's clear aligner treatment. Thus, it is crucial for any practitioner providing clear aligners treatment for patients to have an in-depth theoretical and practical knowledge about attachments and their use. So here we start. What are attachments? Attachments are extensions that are placed on the tooth surface to aid the aligners in difficult movements. They are made of composite material and are placed by the practitioner at the beginning of the treatment using special templates provided by Aeon. Choice of attachment, its shape, size, and position on the tooth will be customized for each case according to the intended movement, as well as the shape and size of the tooth, while taking into consideration any interferences that might result. When submitting a case, A special section is available to specify any attachment restrictions, as shown in this tooth chart here. Press on any specific tooth, and its color will turn blue to indicate attachment restriction, and this will be followed in treatment planning. If there are no restrictions for attachment placement, it is recommended to keep and follow Aeon's recommendation for attachments, as those are designed and placed individually for each case in a way that achieves best predictability for the movements. Attachments will be indicated in the virtual 3D plan video as green-colored extensions on the tooth, as shown in the graphic. After getting an idea about what attachments are, we move forward to understand why we need those attachments. Attachments will work as a handle to the tooth to allow the aligner to apply forces and move the teeth in the three-dimensional space. The flat surface of the attachment, also called the active surface, provides leverage for the aligner to apply enough force to move the teeth. Let's go back to aligner biomechanics to understand why we need attachments. How do aligners move teeth? Remember, aligners are removable appliances that work with a push force, unlike fixed braces which apply a pull force to move the teeth. So the aligner needs a flat surface to push against to be able to achieve proper tooth movements. When that surface is not readily available due to the shape of the tooth, that's where attachments become essential. To understand more, here is an example showing a transverse view of an incisor covered by the aligners. Its rectangular shape will enable the aligner to push against its edges and rotate the tooth in the desired position, as shown in the diagram. Now, let's imagine the same thing for a cone-shaped tooth. Imagine trying to rotate this canine, for example, with aligners alone. Its shape does not provide a flat surface for the aligner to exert their push force. Here is where attachments come in handy. The aligner will use the flat surface of the attachment to push and rotate the canine. Now, moving forward, attachments can be classified into two categories according to function. They can be either active or passive. Active attachments are used to achieve some difficult movements. Some examples for those movements are difficult rotations of canines, premolars, and molars due to their shape and size, root control movements needed in mesiodistal bodily movements, and tooth angulations. Remember that aligners cover the crown part of the tooth only, so to control the movement of the root, we need an attachment to create a counterbalancing force to control root movement and minimize tipping. And, of course, with extrusion movements. Passive attachments are used for retention. Examples include in expansion or retraction movements, and in cases of short clinical crowns. If we are attempting to move or retract the whole anterior segment, the posterior part of the aligner will lose its grip. Hence, retention attachments are used. Now let's move on and talk about different attachment shapes used by Aeon. The photos here show horizontal, vertical, and rotational attachments. And here is the biplane rotational attachment, root control attachment, and the last one on the right is the extrusion attachment. Next in this module, we will talk about each one of those with more in-depth details, including when and where they're placed and the purpose they achieve. Here we go. Now we will start discussing horizontal beveled rectangular attachment. This is usually placed on molars and premolars and serves multiple functions, first of which is aligner retention. It is also needed when applying buccolingual movement of posterior teeth and for extrusion of premolars and molars. Previously, attachments used were pure rectangular with no bevels. This meant that the aligner needs to be fully seated over the perpendicular edges. Otherwise, the teeth might not track well, or even worse, move in an unintended direction. Beveled attachments have resolved this issue and will facilitate insertion and removal of the aligners. Next is the vertical beveled rectangular attachment. Vertical attachments come with two active surfaces that enable root control movements, while attempting to move the teeth in mesiodistal directions. It can be placed on molars and premolars, canines, lower incisors, and upper laterals. Vertical beveled rectangular attachments also play a role in aligner retention. It is also used for mesiodistal movements of posterior teeth and to control the axis of upper and lower anterior teeth with mesiodistal movements and angulations. Moving forward to the extrusion attachment. The graphic shows the shape of the extrusive attachment from a frontal and a side view. The gingival slope provides a surface for the aligner to apply its forces for absolute extrusion. This attachment can be placed on upper and/or lower incisors and canines. Extrusion attachment is a necessity whenever any anterior teeth extrusion is planned. It can also be used to control the torque of anterior teeth, especially when a good amount of labial translation is planned in cases of crossbite. Next is the rotational attachment. This is usually placed on canines and premolars when they're being rotated. Remember what we said earlier about rotation of cone-shaped teeth with aligners. With the rotational attachments, the active surface, which is the flat one, is used to apply a rotational force along with vertical forces to rotate the teeth and prevent any unwanted intrusion forces during rotation. Here is the biplane rotational attachment. This is usually placed on upper lateral incisors and lower central or lateral incisors. The planes of this attachment will help provide extrusion with simultaneous rotation or tipping. And last is the root control attachment, which consists of two half-elliptical attachments that provide two active surfaces for forces to be applied on. This will prevent tipping movements and achieve better control of root position during mesiodistal movements. It is usually placed on upper central incisors and upper canines. It is used in cases when we're planning diastema closure or midline correction, and for any correction of mesiodistal tooth angulation. Note that their function is somehow similar to vertical attachments if placed on anterior teeth, as these two provide two active surfaces for application of forces. However, root control attachments were found to be more aesthetic. That's why they substitute the vertical ones on anterior teeth. Here is a useful table that summarizes some of the most common movements applied in orthodontics and the attachment needed for each specific tooth. When talking about attachments, we have to think about one important point. A patient who steps into our office seeking clear aligners treatment as a removable transparent orthodontic alternative might be hesitant to have anything bonded to his or her teeth. However, emerging evidence suggests that clear aligners with attachments are considered more aesthetic when compared to other fixed orthodontic appliances. Now, after discussing all the theory behind attachments and their placement, let's move to the clinical tips on how to place attachments. Start with checking your stage progress sheet, which comes with the aligner kit. This will indicate when and where attachments should be placed. Check your template sent with your Eon aligner kit. Rinse it with cold water and test the fitting. The next step is to get our armamentarium ready for bonding attachments. You will need Dental Explorer, etching gel, bond, composite material, light cure, and an optional isolating material or petroleum jelly. Next step is to isolate and prepare the teeth that need attachments with etching and bonding. Apply a small amount of composite in the attachment pocket, slightly overfilling them. A useful tip is to apply a very light coat of petroleum jelly in the attachment pocket prior to placing composite. This will assist in easier removal of the attachment after composite is fully cured. Fully seat the loaded template and assure the attachment conforms to the teeth. Apply attachments of each quadrant separately. It is usually recommended that no more than 3 attachments are placed per quadrant simultaneously, as this will affect the insertion and removal of the template. Slight pressure needs to be maintained on the attachments during light curing, according to the manufacturer's instructions. Remove the template and excess flash material using finishing or carbide burrs. Keep in mind that having well-defined attachments is key when considering the aligner's fitting and good tracking of movements aided by attachments. Always check and make sure to avoid excess flash and deformed attachments, as those will impact the treatment. One important feature of clear aligners that is worth discussing here along with attachments is bite ramps. Those are defined as unfilled projections of the aligner placed on the lingual surface of the upper incisors to help in correction of deep bite cases. On the treatment setup simulation, you'll see them as green buttons, just like attachments, on the palatal surface of upper incisors. But those should not be filled with composite or bonded to the patient's teeth, but rather will be a projection of the aligners only. They are intended to achieve 2 functions: act as bite razors to disocclude posterior teeth and allow some extrusion to happen. Apply extra pressure on lower and/or upper anteriors during occlusion to intrude them.
Eon treatment packages. In this module, we will discuss the different treatment packages offered by Eon and set some general guidelines on how to choose the proper package for your aligner's case. Eon offers 3 different treatment packages: Basic, Plus, and Pro. The packages mainly differ in the number of aligners and refinements provided. Basic package includes 10 aligner steps, 1 free refinement, and 1 free set retainer. You will have a 9 months treatment period. Plus package includes 11 to 24 aligners steps, 3 free refinement, and 1 free set retainer. You will have 18 months treatment period. Pro package includes unlimited number of aligners steps, unlimited number of refinement steps, and 1 free retainer. You will have a 36 months treatment period. So, how do I choose? When submitting your Eon case, you will be required to select the package type for the case as shown here, either Basic, Plus, or Pro. Remember that the main distinction between the packages is the number of aligners. So, the first thing to consider is case complexity, which is reflected in the amounts and combinations of different movements planned to reach the final proper alignment, which will eventually determine the number of aligners. The second point to consider is treatment goals. So, regardless of the complexity of the case, what am I aiming to correct in this treatment? The first point to discuss is case complexity. Remember that Eon treatment setups are planned according to specific rates for each type of movement per aligner. For example, rotational movement is done at a rate of 2.5 millimeters per aligner. So if we are planning to rotate a canine, say with 40 degrees rotation, for example, then we have exceeded the number of 10 aligners provided in the basic package. The same goes for cases where extrusion, intrusion, expansion, or retraction movements are required. So the first guide is the amount of movements needed. The next point to consider is the combinations of different movements. For example, if we are planning proclination and extrusion for a specific tooth, then those 2 movements are antagonistic and cannot be done simultaneously. So proclination is planned first and then extrusion, each in its predictable rate of movement per step. So even if the amount of each movement alone can be achieved in 10 aligners, the 2 movements together need to be separated, which will increase the number of aligners and affect the choice of the treatment package. The second variable is treatment goals. Sometimes, even in advanced cases, the treatment is intended to correct some minor malalignment or crowding in the front segment, for example. Let's think of a patient with a class 2 relationship and increased overjet. To fully correct a class 2 with distalization and retraction, This will require a Pro package to accommodate the higher number of aligners needed for those movements. But sometimes, treatment objectives will be to accept the Class 2 relationships and increased overjet, and aim to correct the minor front teeth misalignment only, which will work as a basic or plus package. So, treatment goals are also an important factor in determining treatment packages despite case complexity. Now, let's look at some general guidelines that will categorize the cases treated in each package. Basic is usually indicated for cases of mild orthodontic relapses, very mild spacing and crowding. Indications for plus cases generally include mild to moderate spacing and crowding, up to 5 mm, mild to moderate deep bite, mild to moderate anterior open bite, up to 3 mm, increased overjet, up to 4 mm, mild to moderate anterior or posterior dental crossbite. As for Pro packages, those are indicated for more advanced cases, such as severe crowding and spacing, severe deep bite, severe anterior open bite, antero-posterior discrepancy correction, extraction cases. Remember, this is just a general guide on how to decide what package is needed for treatment. But if in doubt, no need to worry, as Eon's treatment planning team will update you if changes to the packages were needed to accommodate the movements and treatment goals. You will receive an inbox message about any of those changes if applied. So what are the factors that will be considered when upgrading a case? Upgrade will be advised if the rate of movements applied was very aggressive to stay within the limit of basic or plus package. This will affect the tracking of the case and the final result, thus an upgrade will be advised or applied. When treatment objectives cannot be met within the chosen package because of the limited number of aligners. And last, when the final result is compromised due to the restricted number of aligners, then an upgrade is advised as well to achieve better results. Now let's look at some examples of different cases and what type of package to choose for their treatment. This is a case of mild spacing in the upper and lower arches, with stable posterior occlusion of Class 1 molars and canines, and with good overjet and overbite. The treatment plan would include retraction of upper and lower anterior teeth to fully close spaces. So generally speaking, mild spacing like this here can be treated within the basic package. This is a case of moderate spacing in upper and lower arches. The case can be treated with a plus package to accommodate the amount of retraction needed to close upper and lower spaces. Remember that retraction movements are done within the range of 0.2 mm per step. In addition, some other movements were combined, such as mesiodistal uprighting of the upper central incisor, all of which requires that the case be treated as plus. Next is a case for mild lower anterior crowding with stable posterior occlusion of a Class 1. Treatment would address anterior teeth alignment and relief of crowding with a basic package. Here we see another example of a more advanced case of upper and lower anterior crowding with tipped central incisors. A plus package would be a suitable choice to accommodate the movements required, such as posterior teeth expansion, uprighting of upper centrals, and relief of the crowding and alignment. This is a case of a deep bite along with favorable spacing in the upper arch that can be treated with a plus package. Notice that intrusion is a movement that needs space, so intrusion and space closure can be achieved simultaneously to close upper spaces and improve the deep bite in this case. This is a case of moderate deep bite complicated by upper and lower arch crowding. Such a case would require a Pro package. Generally speaking, cases of anterior open bite which require extrusions of anterior teeth of more than 2 mm will require more than just 10 aligners, especially if accompanied with other malocclusions, as extrusion is usually done towards the end of treatment when alignment is almost achieved with a rate of no more than 0.15 per aligner. However, in some mild cases like this one here, where the open bite is localized around the upper left lateral, treatment is doable with a plus package. Here is a more advanced open bite case, where treatment required extrusion of upper and lower front teeth to achieve proper overbite. Next is midline discrepancies, when a very minimal shift of less than 1 millimeter is present, a plus package can be sufficient to achieve midline correction, with some IPR to create space and front teeth movement, of course, if other combined movements are minimal as well. More complex cases of midline discrepancies, like this one here, will require more advanced movements, including posterior teeth movement in most cases, mesialization and distalization, which will need an increased number of aligners and a pro package for treatment. This is a table to summarize the general guidelines followed when deciding on the best treatment package for your aligner's case.
Aligner biomechanics. In this module, we will be discussing the basic biomechanics of clear aligners. Course outline includes a brief introduction to clear aligners biomechanics, along with certain biomechanical considerations for each of the following movements: intrusion, extrusion, angulation, torque, rotations, and translational movements. Clear aligners move teeth gradually through a series of thermoformed tailor-made plastic trays. Each tray has a small increment of movement incorporated in it to help push the tooth into the eventually favorable position. A fundamental difference between clear aligners and traditional braces is that they push rather than pull teeth. Because of the nature of the push force of plastic, some movements are more difficult to achieve than others. In this module, we will run through the different types of orthodontic movements and how understanding biomechanics can help you achieve them with higher predictability. First stop, we will talk about biomechanics of intrusion. When talking about intrusion with clear aligners, it is best to split it into two sets of groups, the first being anterior teeth intrusion and the second, posterior teeth intrusion. Anterior teeth intrusion. In cases where treatment planning requires intrusion, certain considerations should come in mind. Intrusion of anterior teeth is a movement that needs to be planned carefully, taking into consideration that forces need to be applied both lightly and gradually. Intrusion of anterior teeth will exert an extrusive counteractive force on posterior teeth. Retention of the aligner is compromised because of the dislodging forces posteriorly. To overcome these problems, consider planning your treatment setup taking the following 2 points into consideration. Bite ramps, as shown in the figure, are an aligner feature on its palatal surface. It serves the same purpose as traditional braces. They are placed on the upper incisors and/or canines and serve two main functions: disoccluding posterior teeth. This will help unlock the bite and remove any bite interferences or forces if present. It will also help provide room for any passive extrusion to occur through over-eruption of teeth. In addition, they serve to apply intrusive forces on anterior teeth. This illustration shows how bite ramps appear in the 3D treatment simulation. Note that they are viewed from the top view of the arch as they are placed on the palatal surface of teeth. Second consideration is attachments. The importance of attachments on teeth adjacent to those being intruded is twofold. Firstly, retention to prevent the dislodging forces acting on the posterior teeth, and secondly, when intruding anterior teeth, a counteractive force will tend to extrude posterior teeth as a result. Having attachments on these teeth will provide anchorage to counteract these extrusive forces. When placing those attachments, consider placing them on the premolars, where the highest extrusive forces are being applied, but also consider adding them on the first molars, where extrusive forces might extend. As for canines, always add attachments, even when intruding them with the incisors. This is because usually incisors require more intrusion than canines, meaning that some extrusive forces tend to affect them. Therefore, it is always recommended to have attachments on the canines. Posterior teeth intrusion. In cases where posterior intrusion is desirable, consider the following: With clear aligners, posterior intrusion is less predictable than anterior intrusion. Plan movements in a slow rate, making sure no antagonistic movements are occurring simultaneously. Consider adding attachments on teeth adjacent to those being intruded to enhance anchorage and counteract unwanted movements. When intruding posterior teeth, you could consider the use of auxiliaries, such as temporary anchorage devices, TADs. Their use depends on the amount of intrusion required, with increasing intrusion necessitating the use of TADs, and also when counteractive extrusive forces of anterior teeth are to be avoided. Moving on to biomechanics of extrusion. Extrusion is one of the movements that require altering the shape of the teeth. This is done through the use of attachments, as you can see in Figure 1. Adding an attachment on the incisors has given the aligner a surface to push against. Relative extrusion is a term used when teeth are being lingually or palatally tipped. This will affect the appearance of the incisal position. Therefore, you need to bear in mind that correcting a proclined tooth will result in relatively extruding that tooth as well. This is shown in Figure 2 below, where tooth in A is being relatively extruded when tipped lingually or palatally, and B, where it is being vertically extruded. This is referred to as absolute extrusion. As we discussed in the previous slide, extrusion requires the addition of attachments. The type of attachments depends on the position of the tooth within the arch. Extrusive attachments, shown in Figure 1a, are placed on all anterior teeth during extrusion. Synergistic movements that are favorably combined with anterior extrusion is retraction. This is because the active surface of the extrusive attachment comes at an angle to the long axis of the tooth, as shown here in Figure 1b. So extrusion and retraction can favorably occur together. This is not to say that extrusion must be coupled with retraction, but it means that if both movements are happening, combining them together will increase predictability. As for posterior teeth, horizontal rectangular beveled attachments, shown in Figure 2, are used when planning extrusive movements. Another movement to discuss its biomechanics is angulation, or what is commonly known as mesiodistal tipping, or uprightening. Uprighting a tooth requires two forces of equal magnitude acting in opposite directions, as shown in the figure below. Uprighting a tooth requires surfaces for the force to be applied on. When uprighting, these surfaces would be the mesial and the distal surfaces of a tooth, in case of spaces which would allow the plastic to wrap the tooth and tip it as required. However, when such spaces are not present, or when the amount of angulation is significant, the use of attachments is essential to guarantee the predictability of angulating a tooth. EON uses two types of attachments when correcting angulation. The vertical rectangular beveled attachments shown in the figure to the left and root control attachments shown in the figure to the right. Both serve the same purpose. However, since the root control attachments are smaller blobs situated on the side of the tooth, they are perceived as more aesthetically pleasing. Therefore, they are commonly used in cases where angulating upper centrals is required. Now moving to the fourth movement biomechanics, which is torque. What is torque? Sometimes referred to as inclination. Torque is moving a tooth around its center of rotation in a buccolingual or palatal direction, where the crown moves in one direction and the root in the other. It is one of the difficult movements to obtain orthodontically, not just with clear aligners. Therefore, it is advisable to over-treat torque movements to compensate for any lag that could happen. The first step in managing torque is to differentiate between teeth that require changing their torque from those which need their torque to be maintained. Firstly, we will discuss what is needed to maintain torque. Let's consider this tooth for example. When moving it bodily in a buccal direction, buccal inclination or tipping is bound to happen along the way. To counteract what we've seen in the previous slide, plan the movement in a way that includes attachments as shown in the figure, so that every time the tooth tips or inclines buccally, the attachment will exert an extrusive force to correct its inclination. Another way to maintain the buccal-lingual inclination is to compensate for the anticipated movement. For example, expecting a buccal inclination in the setup and compensating for it by planning a lingual or palatal inclination. Maintaining anterior torque during retraction. This is essential to prevent lingual or palatal crown tipping. Torque enhancers are little dents on the buccal gingival surface of a tooth. As you see in the figure, the aligner applies its most force on the incisal part, and torque enhancers would apply it on the gingival part. These two forces together, applied in the same direction, make sure that the tooth moves in a translational movement rather than incline or torque. Changing the buccal lingual inclination of anterior teeth. Inclining teeth labally requires the addition of buccogingival torque enhancers as well. This is because the aligner will exert a force on the palato-incisal part of the tooth, and the little dent on the buccogingival surface will also exert a force to enhance the movement as a result. When inclining an anterior tooth lingually, consider adding extrusive attachments. This can be explained best by the figure here, where an extrusive attachment is positioned in a way that makes it have a horizontal component as well, which would help tip or incline the tooth palatally or lingually. Now, moving on to rotational movements. There are two types of rotational movements: pure rotation, where the center of rotation is the long axis of the tooth, and hinge rotation, where the center of rotation is on the mesial or distal aspect of the tooth. The choice between each depends on your preference. Some dentists find hinge rotation to be a more predictable movement to plan than pure rotation. Pure rotation is the default for Eon Technician, unless you specify in your treatment plan that you wish to have the hinge axis rotation on a certain tooth. Attachments are key for a successful rotation of cuspids and bicuspids. Without attachments, cuspids will have a tendency to rotate less efficiently and intrude, as seen in the first diagram. By providing a flat, active surface for the aligner to push against, as seen in Figure D, this will help rotate the teeth with more predictability and also exert extrusive forces to hold the tooth in place to counteract the intrusive forces that are pushing the tooth into the bone. The sixth movement we will be discussing in this module is translational movements. Translation includes movements in the mesiodistal and buccolingual directions. We have covered the buccolingual translational movements when we talked about maintaining the torque of teeth. So in the next few slides, we will focus on the mesiodistal translational movements. Mesiodistal translational movements may require the use of attachments to prevent crown tipping. Other than the fact that tipping is unsightly and creates what is called a black triangle, it increases the risk of relapse when the crown moves but the root doesn't follow. Attachments used are usually vertical, rectangular, beveled. Using root control attachments for centrals has been shown to have similar effects, but higher aesthetic perception. Similarly to buccolingual translational movements, mesiodistal translational movements in the 3D simulation need careful planning so as to avoid tipping, as shown in this graph. Adding an attachment to the tooth being translated makes sure that this tooth moves bodily and decreases the risk of tipping. Also, as we've discussed with buccolingual movements, consider compensating the movement. For example, if the plan is to move the tooth mesially, then add some distal crown tip to compensate for any mesial crown tip that may occur. Still in the topic of mesiodistal translational movements, we'll talk about sequential distalization and mesialization. When planning sequential distalization, consider the following. A maximum of 3 millimeters of distalization is predictable. Mesial outrotation of the upper first molars is often indicated in Class 2 treatment. This should be done concurrently as the first molars start moving distal, as it will reduce the distance they need to move to obtain a Class 1 relationship. The presence of upper wisdom teeth may hinder the distal movement. Even impacted wisdom teeth can affect results. Use of auxiliaries like elastics, type of which depends on movement desired, for example, Class 2 or 3. Vertical beveled attachments will help with root control as teeth move distally. Distalization works better in younger patients. It is common to have increased number of steps and a long treatment duration when planning sequential movements. How to plan sequential distalization. Start by distalizing the second molar only. Once second molar is halfway through, start moving the first molar. Once second molar has reached its position, start planning movement of the second premolar. Start distalization of the canines once first molar has reached its position. Here's a video showing the distalization in a sequential movement. Second sequential movement is the sequential mesialization. A maximum of 2 millimeters of mesialization is predictable. Use of auxiliaries like elastics is essential to help reinforce the movement and provide intermaxillary anchorage to counteract unwanted movements. Mesialization increases the number of steps because of the need for it to be performed sequentially. Similarly to distalization, mesialization is done sequentially as follows. Start by mesializing the first premolar. Once first premolar is halfway through, start moving the second premolar. Once first premolar has reached its final position, start moving the first molar. Once second premolar has reached its final position, plan movements of the second molar. Here's a video showing the sequential mesialization in a sequential movement. Lastly, we will be talking about some special considerations that need to be taken when planning an extraction case. Consider sequentially closing space. Prevent crown tipping by using the proper attachments and by continuous monitoring and tracking of the case. Increase movement predictability through proper staging of movements and/or the use of elastics. This would also help to maintain good anchorage. Treatment may necessitate the use of sectional fixed braces at the end of treatment to align the roots.
Although clear aligners emerged as a game changer in orthodontic treatments, they initially faced challenges rotating certain teeth, in particular cone-shaped teeth, as these lacked sufficient surface area for the aligners to push against. To overcome this, attachments were developed, which are tooth-colored composite extensions bonded to the teeth to provide additional leverage and help move teeth more efficiently. Attachments have come a long way since their inception and are now used for a wide range of tooth movements, including, but not limited to, uprighting teeth and keeping roots parallel during bodily tooth movements. In fact, they are a critical component of clear aligner therapy and have become indispensable for achieving optimal treatment outcomes. Let us see how these tiny attachments have revolutionized the world of orthodontic treatment by learning how to place them. To place attachments, you will receive an attachment template along with the aligners package placed in a separate pouch marked as T1. The number indicates the step at which the attachments need to be placed. If your treatment involves interproximal reduction before step 1, we recommend performing the attachment bonding procedure first to avoid any complications caused by gingival bleeding during IPR. Now, let's get started. First, rinse the attachment template with cold water and let it dry. Then, test fit the template on the patient's teeth, ensuring that it covers all the teeth and fits snugly until the last tooth in the arch. Check out T1 here. Notice how the template fits tightly. with no gaps between the incisal edges of the teeth and the template. In this case, we can proceed with the attachment bonding procedure. It is also a good practice to ensure that aligner number 1 fits properly before bonding the attachments. This will be useful later if problems in the aligner fit are noticed. Sometimes, you may encounter a poorly fitting template due to poor quality impressions or, less likely, a manufacturing defect. In such cases, never attempt to place the attachments using that template. Instead, try aligner number 1 to check the fitting and use it as a template if it fits perfectly. You can even cut the template in half to check the fitting and then use it for attachment placement if it still fits the teeth as desired. But what if both the template and aligner number 1 do not fit correctly? This issue most likely results from an impression quality problem. In such cases, it's best to obtain new records and request an adjustment. Another scenario you may encounter is when the template fits well on all areas of the arch except 1 or 2 posterior teeth. In this case, you can try pushing it over the posterior teeth and proceed with attachment placement. Make sure to use four-handed dentistry and ask your dental assistant to firmly hold the attachment template in place while curing the composite. If you feel it is challenging to use aligner number 1 as a template since it is made of a more rigid material, you can request a template replacement after making sure there is no impression quality defect. Moving on to the next step. To ensure accuracy, check the number and shape of attachments provided in the template and compare them to the attachments present on the 3D viewer on Eon Access. Once the fitting and attachment analysis is complete, it's time to prepare the teeth for attachment bonding. The teeth should be thoroughly cleaned, polished, dried, and isolated. It is advisable to place the attachments in quadrants or sextants. That is, limit the number of attachments placed at a time to 3 or 4 to ensure better moisture control and easy removal of the template. Next, we apply phosphoric acid for 30 seconds to etch the area and create a suitable surface for bonding. Be careful not to etch the entire tooth surface, but only the area where the attachment will be placed. After that, we rinse for 30 seconds and dry the area until a frosty appearance is visible. Then, we prepare and apply the primary adhesive material to bond the attachment to the tooth surface. Gently dry the bonding agent after application and light cure as directed by the manufacturer. If you are bonding attachments to crown teeth, then the process is a little different. Use hydrofluoric acid for etching and a silane bonding agent instead. Now, it's time to fill the attachment template with composite material. You can use either conventional restorative composite or flowable composite. Start by carefully filling the attachment template, making sure not to overfill or underfill it. Tap the attachment template on a hard object to remove bubbles and check the attachment pockets for deficiencies. A helpful tip is to apply a thin layer of separating medium like petroleum jelly in the attachment pocket before placing the composite. This makes it easier to remove the tray later on. Now, place the attachment template filled with composite material onto the patient's teeth. Ensure it fits well by applying gentle finger pressure or asking the patient to bite on a cotton roll. You can even use a dental instrument like a probe or tweezers to apply pressure and make sure each attachment is properly adapted to the tooth. Follow the manufacturer's instructions to light cure the composite material. To make things easier, start curing from the most posterior tooth, where moisture control is a bit more challenging. Carefully remove the attachment template and inspect each attachment. At this stage, you might encounter problems like attachment debonding or partial fracture. This could happen because of a poor bonding technique or lack of proper moisture control. If you're placing attachments in quadrants, begin removing them from the side where no attachments are bonded. It's also a good idea to start from the palatal or lingual side. If the template feels too tight, use a dental instrument or carver to separate it slightly from the gingival side before pushing it away from the teeth. If an attachment completely detaches during template removal, no need to worry. You can simply remove the composite within the pocket and repeat the procedure using the same template. Additionally, if one attachment debonds during treatment, you can reattach it using the current aligner step as a template after ensuring the fit is perfect. Use a carbide finishing burr to carefully remove any excess composite material, making sure not to apply too much pressure or change the original attachment's shape. After removing the excess composite material, use dental floss to check the contact areas for any remaining composite. Finally, insert aligner number 1 into the patient's mouth and ensure it's fully seated. If you notice any areas where the aligner doesn't fit properly, double-check that no excess composite is affecting the aligner seating. When placing attachments on your patient's teeth, keep these important tips in mind. Firstly, limit the number of attachments you place to no more than 3 per quadrant at a time. This will ensure better moisture control and make it easier to remove the template. Secondly, make sure your attachments are well defined, as this will help your patient's teeth move properly during treatment. Thirdly, if your attachments come out deformed, it may be because you didn't put enough composite material in the template. So make sure to slightly overfill the pocket when filling it. Lastly, be careful not to greatly overfill the pocket with composite material, as this may result in excess flash. Instead, slightly overfill it and tap the template to remove any bubbles. We hope these tips help you master the art of attachment placement for your aligner patients and achieve great results.